Welcome to this Mtech Access webinar. At Mtech Access, we provide health economics and outcomes research and market access services from strategy through to implementation. We work with over 80 NHS associates to bring our pharmaceutical and medtech clients authentic insights into the NHS. Our unique NHS relationships guide and validate everything we do in the UK. We can help you answer key questions related to the NHS, from how to communicate with integrated care systems, places and primary care networks, to how to capture pathways of care. Get in touch today to discuss your market access goals. First though, I hope you enjoy the webinar.
Good afternoon, everybody. Welcome to the Mtech Access Words of Wisdom webinar. I'm Tom Clarke. It's great to be back speaking to another prominent colleague from the health and social care archipelago to examine yet another dimension of the future of care. And apologies this week that our GoToWebinar platform is having challenges with their webcam support, so we can't bring you pictures of us, but instead we've got a static picture of us, which I'm sure is probably more than enough for you. So we're just audio this week rather than video. Today I'm delighted to be joined by Dr Steven Laitner, a GP from my hometown of St Albans, with a much wider interest in all elements of personalised and population health. Highlights from his impressive CV: Steve's been a national clinical lead for shared decision making, a clinical advisor to the National Association of Primary Care, and continues to work as a consultant across many geographical and clinical areas to promote personalised care, amongst other things. So in my conversations to date, we've explored much of the policy and theory around the NHS changes. You'll notice we're increasingly getting close to the practicalities of how change will be driven. So today we'll be speaking about population health and how that can become a reality for individual patients. So Steve, welcome. Thank you for joining me today.
Thank you, Tom.
Just to kick us off, could you just, for the audience's benefit, describe some of the roles that you occupy at the moment and a little bit about the systems that you're working in?
Yeah, no, of course. Thank you, Tom. And I was reminded of the old quote, I think it was from Terry Wogan, who described himself as having a face for radio. So you're all lucky you're being spared video on my part today. So I'm a practicing GP in St Albans. I've just logged on to my computer here at Parkbury House Surgery, ready for afternoon surgery with a slightly delayed start at 3 o'clock. So I'm a salaried GP part-time, but I've got a public health background. I was a public health consultant for a while before moving into leadership roles at a strategic health authority and national level around long-term conditions and shared decision-making and pathway redesign and the like. And I feel really the place I've come to at the moment, which is a freelance consultant working for a number of NHS organisations and consulting organisations, really firmly in the space of population health management, which we'll come on to a discussion about exactly what that is. But I've felt, not to sound too trite, but I've felt I've sort of come home. My career has been, a mixture of general practice and public health, and sometimes those have been felt a bit like parallel streams. But I think population health management really brings together the best of public health thinking, clinical practice, and thirdly, a focus on patient and care experience. So really freelance population health management is my thing when I'm not being a GP, which I will be after this call.
Fantastic. We'll make sure we finish on time, so we're not holding you back from your patients. So Steve, you talked there a little bit about population health management. What is population health management?
It's a great question, and I think it's where it all starts, really. We have to sort of define the terms we're speaking about, and I think there's a lot of problems where people conflate or confuse population health and population health management. It's easy to do because two of the three words are the same. So there's a good definition which you can find on NHS England website. Essentially, population health or public health is about identifying priorities in an area. That could be a country or a local authority or a neighbourhood, identifying priorities and interventions that work on a community level. So things like, I suppose, public health intervention, population health interventions that we've grown up with, compulsory wearing of seatbelts, smoke-free public places, reducing the age or managing when people are able to buy alcohol or tobacco, ensuring access to healthy food, good transportation, education, housing, etc., etc. It's population health, public health, I think, are the same thing, and they're focusing on whole population issues and whole population interventions. Population health management is really at the cohort level. It's identifying groups of people with similar needs, and that could be older people with frailty, it could be working age adults with multimorbidity, it could be children with complex needs, it could be people who are at risk of developing long-term conditions like prediabetes and obesity, but it's working at a subpopulation level, identifying a priority area, and then after looking at a priority area like multimorbidity or multiple long-term conditions, then actually using data and analytics to identify a cohort of people with that priority in order to target them in terms of identifying them for health and care interventions. So literally, somebody would identify a list of people with similar problems, and somebody would call them up or message them and enroll them in a program of care. And that program of care will tend to be a proactive and holistic program of care rather than being reactive or disease specific. You may though get to the priority through a disease specific way, but the intervention, in my book anyway, should be a holistic, personalised, person-centred type of intervention. I'll stop there because I could go on, but I'll stop for now.
You'd make my job very easy. No, that's a great oversight, Steve, and we're going to get into some of the detail of the what and the how. Just you touched on sort of public health being at the population level and population health management, looking at specific cohorts. How does a population health management differ from traditional public health approaches of targeting smoking within pregnant women or other things like that? What distinguishes it? Why is it different from what's gone before?
Well, let me think. So let's take your example of targeting pregnant women with interventions that's going to improve their health and the health of their unborn child, which would seem a very good thing to do. I suppose public health interventions would be more about identifying every pregnant woman in an area, or that might be, as I say, the country or a county or a town, and then applying interventions that might be specifically smoking cessation interventions, or it might be other interventions. I think what population health management would be about would be honing in on that priority, perhaps looking at inequalities. It might be worth, if you've not looked at it before, the Core 20+5 NHS England approach to targeting those people who are likely to suffer inequalities of health, perhaps by virtue of their ethnicity or their disability or the other conditions that they have. So population health management would sort of hone in and find pregnant women of a certain ethnicity, perhaps in a certain area, maybe those who have long-term conditions already. And I expect, this might be wishful thinking on my part, but I would expect with population health management, the interventions would not be just focused on the specific intervention like smoking cessation, but would be focused on other ways to improve the health and well-being of the pregnant woman and their unborn baby. Maybe looking at diet and exercise and alcohol intake and caffeine intake and good mental health well-being and support and all those things, rather than just focusing on a single risk and a single intervention. So narrow in some way, maybe more narrow in focus than public health, but perhaps broader in the way that somebody is supported once they are identified.
Yeah, fantastic. Thank you, Steve. So with all that in mind, what do you see as the potential impact of health and social care taking a population health management approach?
Well, I think in short, if you're looking at integrated care, coordinated care, it's great to have a focus. It's great to have a priority. It's great to have something to work on together. So I'm doing a lot of work at the moment, a programme of work for NHS England, led by PA Consulting. I'm working within that consortium for a company called Solace, and we're supporting a number of places across the country. So as you'll all know, there's the integrated care systems at a sort of sub-regional level. I'm working in Hertfordshire and West Essex, for example, as the ICS. The place I'm in is Hart Valley, which is sort of West Hertfordshire, St Albans, Welwyn Garden City, Watford, that sort of area. And the place is where different provider organisations come together to work together in order to deliver more joined up care for the residents in that area. And some of that particularly comes together in a primary care network. So let's say in the primary care network where I sit in St Albans, there are, I think, 3 primary care networks in St Albans. What population health management would help bringing together health and all elements of healthcare and social care is by finding a priority, a health need, and a group of people who would benefit from the collective assets of that community and are able to deliver joined up care. So one quote I often use, what I made up, as I do many, is there's a lot of talk about integrated care, but what I think people forget is actually there's a lot of people who don't need integrated care. There'll be quite a lot of people on my triage list, which I'll get up on my screen in a moment to see what awaits me when Tom's doing more of the talking. It's just so I'm logged on, which can take a while. There'll be a lot of people actually who don't need integrated care. They're generally 20-year-old who thinks they might have a urine infection, a toddler with an upper respiratory tract illness, and really what they need is good access to primary care and a quick call with a clinician. That might be a physiotherapist if it's back pain, could be me if it was sort of undifferentiated demand. They need quick access to somebody who cares and knows some stuff and is able to support them. However, there'll be a number of people in the population who really need integrated care and highly personalised care and high degrees of continuity. For example, people at the end of life, people with learning disability and other health challenges, people with a mixture of health and drug and alcohol problems and social problems. Those are the people who need the collective resources of a local area with health and social care and housing and other agencies working together. But we need to find those people. And that's what population health management is about in my book. It's finding those people who need that integrated care. And actually some work I'm doing in Frimley, actually identifying those people. So when they call the surgery and the red flags up and there's been a population segmentation, population health management exercise, and there's a flag on the person's notes to say they've got complex needs, and the call handler would try and ensure that that person speaks to somebody who knows them really well. So although mainly population health management is about proactive care and anticipatory care, actually there is a role of population health management to segment the population in order to deliver more personalised care to the individual who's calling, be that they don't really need high degrees of continuity, or they really do need high degrees of continuity and potentially more multidisciplinary approaches.
Yeah, okay, that's really useful. And I suppose the follow-on to that, you've mentioned both places and PCNs in your summary there. Do you see that there will be a home for population health management, or will that depend on what the particular cohort is, what the particular geography looks like? Is it that its place is always going to look after this, or might some things be PCN, might some things even be at an ICS level?
So I think it's sort of horses for courses, really, and I think all bits of the system have to play a part in population health management. I think population health management is here to stay. I think it's reached a stage where everybody is beginning to understand what it is, or most people are beginning to understand what it is. Hopefully, through the next 45 minutes, we'll be able to help people's understanding of population health management. And I think people get it as to how it can help us provide a more sort of nuanced health and care service. And I think one of the things that COVID has taught us is that people have very different experiences and outcomes from a health threat. So we need population health management. And I suppose during COVID, we saw it in action. We identified people of a certain age who required vaccination in the beginning of the pandemic. Fairly simple population health management, just identifying people by age, but it is population health management. And then we got into identifying people not just by age, but by health conditions and disabilities, and then we understood more about the impact of ethnicity. So that was real population health management, and I think that's accelerated future work. So in terms of the roles of different bits of the system, so clearly NHS England have got a role in ensuring that population health management capability flows through the system at a regional, at an ICS, at a place and at a neighbourhood and PCN level. I think those is just different functions. I think the ICS has a responsibility to ensure the right data and analytical capability across the system, and I think they have a target. I think it's by 2023 they have to have a patient level linked data set in operation. So they're about the wiring and the infrastructure and the strategy. The place, I think, is going to be where the analytics happen, where we would do the segmentation, which I can talk a little bit about what that means, the restratification, the picking out of, I don't really like the term, but sort of actionable cohorts of people. That's where the infrastructure of that the ICS has afforded is used to do the data and analytics and the segmentation. And then I think the PCN and the neighbourhood level is where the care gets delivered, and at the practice level as well. I mean, some of the care will be at the place level rather than neighbourhood level, and maybe some of the care, if you're talking about sort of tertiary care, will be at the ICS level. But generally, I'd see it that ICS is about population health management capability, sort of infrastructure. Places is about doing the data and the analytics using those tools, and the PCNs within the place and the practices is where the care gets delivered.
Yeah, okay. Yeah, that's a really nice way to categorise it. I suppose the follow on from that is, where does the responsibility, or is there any accountability for the implementation of these things, or is that still down to the practice, the PCN, to deliver the right level of care, or does the accountability sit higher with these kind of things?
I think the accountability sort of rests across the system in terms of what we're we're talking about. So I suppose the ICSs have the accountability to ensure the infrastructure is there, and I'm sure they'll be held account in the good old traditional way by NHS England and its regional headquarters to ensure that that happens. I'd say the places, and I'm doing a lot of work with places at the moment. I just came off a call this morning, probably shouldn't say which place it was, but a great place up north that are doing really good things, and I suppose they're accountable to ensure that they're doing some of the place-based prioritisation, and they're doing the analytical work, and they're identifying the cohorts. And then I suppose the primary care clinical directors and the teams in primary care and community care and social care and voluntary sector and community assets will probably have the requirement to actually do the doing. I think in a sort of Goldilocks sort of a way, I think probably the places where most of this is going to happen, you know, the ICSs are probably a bit cold, and the PCNs are probably running a bit hot, and the practices certainly. The place is probably where a lot of the magic is going to happen, and the places are going to. I mean, you could turn it around the other way and say the ICSs are accountable to the place to have the infrastructure for them to use, and the places are sort of the places are in a way accountable to the PCNs to ensure they deliver the potential for joined up care by ensuring that local organisations work well together.
Yeah, okay. Yeah, that's all nice and clear. In terms of population health management, so we've talked a bit about kind of the approach in general, I suppose, there. Translating all of that into practice is quite another matter, isn't it? You've talked a bit about some of the things that you're working on at the moment, but could you expand on that and give any more examples of specific things you've been working on? Possibly share a little bit about your 6 care models that you've identified for approaches.
No, thanks for reminding me about the 6 care models, and sorry we can't share a screen with you, which is probably a bit easier. So I've come up with 6 care models. So a couple of those are reactive. I think the first important thing to do is to, and I've got a blog out at the moment. Actually, well, it's not come quite yet. There's one blog I've just done for a sort of a digital workforce platform called Lantern, which is on their Twitter feed and mine, which is at Steve Laitner. That's about population health management. There's one coming next week that's about workflow in primary care, both very much related to each other. So I think the first thing is to decide whether you're talking about reactive care, which I'll mainly be doing this afternoon, responding to calls of people who feel they need to call back from the doctor on the same day because, as I said earlier, they're worried about a urine infection or a chest infection or skin infection or injury or whatever. And I think there's 2 types of reactive care. There's reactive care, and this is what I was talking about earlier. There's reactive care for people who are generally well or don't have complex needs. They might have 1 or 2 long-term conditions, but generally they're okay. Their conditions are well managed. They've either got an exacerbation of a long-term condition, like an exacerbation of asthma, or they've got a new condition. So they might happen to have asthma, but they've injured their knee, nothing to do with their asthma. Okay, so 2 reactive care models, one for people who aren't complex or don't have complex needs, not needing such high degrees of continuity. The second one for people with complex needs who do. And then I think there's 4 proactive care models. So there's a proactive care model, excuse me, there's a proactive care model for preventative care. So this is identifying people, this is population health management in action, identifying people who haven't yet got a long-term condition, but have identified risk factors for long-term conditions. So I could probably go on my EMIS GP system and identify thousands of people who we know have obesity or smoking or drug and alcohol problems, etc., etc. And if practices and PCNs were doing real population health management, they'd probably be reaching out to those people and offering them support to reduce their risk of future disease by helping them go into smoking cessation services and Weight Watchers and physical activity, walking clubs, etc., or sometimes all of the above. So proactive preventative care, then proactive care for single long-term conditions, which I suppose is disease management really. Proactive care for multiple long-term conditions, which is a different approach from just adding up all the long-term conditions somebody has. You don't want somebody going to an asthma clinic one day and a heart failure clinic another day, and then another day a hypertension clinic. You actually want a way of supporting that person and all their needs. And then the fourth and final model, proactive care model, is for people with complex needs. And by complex needs, I developed a matrix which these 6 care models sort of align onto. And essentially the 3x3 matrix, which I developed with a colleague of mine, Mark Davies from Hebden Bridge and National Association of Primary Care, says there's 3 big life courses. I'll come back, by the way, to the complex piece in a moment. But there's 3 big life courses: children and young people, which probably should be 0 to 25. And you could argue, with Tom's speaking about pregnant women, that it should be think about the fetus prenatally, but 0 or minus so many months until 24 or 25 actually. Also evidence the human brain doesn't mature till at least 25, and people are often still in further education or apprenticeships by then. So children and young people up to say 25, 26 to say 65 or 70, working age adults, and then 65 or 70 plus older people. That doesn't mean that they're frail, it just means they're older and they're probably more likely to have a bit more time on their hands, perhaps. But these are just broad categories. You can't generalize about what people are like in those life courses, but it's probably quite important to know whether you're thinking about a 15-year-old, a 50-year-old, or a 90-year-old group of people. And then they're the sort of rows, and then the columns are generally well, no long-term conditions. The middle column, long-term conditions, and the third column is complex needs. And by complex needs, I don't just mean a sort of morbidity count or long-term condition count. I think people are complex or have complex needs because of the combination of their different needs. So somebody with complex needs, I would argue, would have physical health problem or problems and mental health problem or problems. And it's that combination of physical health problems and mental health problems that causes complexity in their needs and their care, or either physical health problems or mental health problems and a disability. So that's what I mean by complex needs. And the 6th and final care model is the proactive care for people with complex needs. And that's going to be about care coordination, care navigation, care and support planning, clinical health coaching. That would be very much in the sort of proactive, personalised, anticipatory care. I suppose for that group, we're talking more about tertiary prevention, preventing decline in function, preventing admission to hospital, preventing admission to residential care. In the middle column, we're more talking about secondary prevention and disease management. And in the first column, we're more talking about primary prevention and preventing people developing a long-term condition in the first place. So clinicians really get interested when we start talking about, okay, well, that's all very interesting, but what are we actually going to do? And it's saying, well, we need to think about these different care models the way we support the different groups of people in our population with different needs, that's when it gets really interesting. So Tom asked about, that was a long way of getting to the examples. So the first bit I've explained the different care models and a bit about the 3x3 population health management segmentation model. Other models are available. There's a Bridges to Health model by ABH. I think they've produced a model called Health Span. Optum have probably got another model. There are different models available, and please do have a look at those. So just give you a couple of examples. One example is work I've done in Frimley and Sussex, which is about segmenting the population and colour coding the health records of everybody in the population. So when somebody calls for help, if they're green, no long-term conditions, amber, long-term conditions, or red, complex needs, and then that helps you work out how to manage them better. And then the second and last example for now would be a model I helped develop in Kent and Medway with a company called Carnell Farrow, and we developed what was called the Dorothy model, which was really a frail elderly model, or a model for people, older people with frailty. And that was where we got into talking about having targeting a group of people, enrolling them in a program of care, and having a care coordinator, a health coach, linking to social prescribing link workers, carer support, medication reviews, et cetera, et cetera, et cetera. I think Filed Coast was a good example in the Vanguard program of this sort of program. So that's a couple of examples. I'm going to have a little bit more of my lunch whilst Tom talks a little bit and then builds up to any more questions.
Brilliant. Thank you, Steve. And I think that way of illustrating those your matrix there is really helpful. Hopefully people were able to sketch that out while you were talking. Unfortunately, we haven't got the video, but we might be able to share something with people after the event so they can sort of visualize that themselves and think about those different groups in those different buckets as a way of how you and your colleagues are going to start stratifying things is really helpful. Just thinking in terms of thinking about maybe the Dorothy program as an example, where you're looking to coalesce different elements of a system around a particular cohort, the frail elderly in that case. In the past, there's been lots of different ways of looking after groups such as that, often done through primary care or community services. When it comes to population health management and really getting it to work in a way that is different and impactful, what do you see as the key enablers for population health management?
Yeah, that's a really good question. And if you don't mind, I'm in the fortunate position of working for quite a few companies at the moment, which keeps me busy and interested. And if you don't mind, Tom, I'll just mention a couple of others who I'm doing other sort of work with. So there's an interesting company called HN, who are they used to be called Health Navigator, but everything's in initials nowadays. So HN, clinical health coaching company, and they also do the AI-enabled, case finding, and that is really a mixture of population segmentation and risk stratification. So it's important to know the difference of those two things. The 3x3 matrix, that's about segmentation, segmenting people into groups of people with similar needs at a very high level. So working age adults with complex needs, children, young people who are generally well, et cetera, any combination of the 9 boxes. So what you might then do is a risk stratification exercise, looking for data that suggests somebody is at risk of either an adverse event or an admission. So that might be looking at people who have had multiple trips to A&E or multiple hospital admissions, or there's other things in the data that tells you, they're about to decline. And the work that HN have done, which is really interesting, and Tom, I'm very happy to share, I think it's a 4-slide deck that they have. So 2 interesting things they found. And this is where part of the trick of making this work is getting the focus right. Yeah. So I think some intervention in the NHS have failed in the past, not because the interventions were wrong, but they just didn't pick the right group of people to target. So what HN have found, and I think this was work in the Midlands, that 5% of a population were consuming in a year 70% of the occupied bed days in the local hospitals. So that's a huge Pareto effect. 5% of the population driving 70% of the occupied bed days. I stress the numbers just because I still I find it quite staggering, that sort of correlation. So, but the other really interesting thing that HN found is that if you take that cohort of high utilisers or super utilisers, only, I think it's 15% of that cohort were still high utilisers the following year. So there's a very, very powerful regression to the mean effect. So you could put in a programme without any control group and assuming that the population were pretty static, and you would see a big reduction in occupied bed days, over a year for that cohort, and you'd assume it was your intervention, whereas it might well be just that things got better anyway, because often things do settle down and then get bad again a time later. So I think population health management needs to be dynamic, like we're talking about, live data. So data that's sort of updated daily, and using that data to drive care and interventions rather than sort of historical data. And then I think the other trick is seeing it as a service for the cohort rather than a service for everybody. So some of the real struggles I've had previously is when you talk about this model and the benefits that it would provide in terms of discharge support, admission avoidance, etc., and you said, these are the interventions we're going to target on this cohort of 375 people. And people say, but there will be these other people who could also benefit from those services. Can't we just expand it? Can't we just allow people to refer to that service if they find somebody? So it's really being very driven and unapologetic in your focus and maintaining that focus. And then rather than saying for that population they're going to have a bit of this and a bit of that and a bit of the other, no, this is the team of people who will be looking after that cohort, and they sort of take off their organisational name badge and they're working for the Margate Frailty Service, not the hospital trust or the community trust or the primary care. So it's really getting that focus, and that's a challenge. And the challenge is a lot of healthcare professionals want to do a bit of everything, and that's fine. And it's not suggesting somebody's going to be in the Margate Frailty Service as a provider forever, but it might be that we need some people to perhaps be a GP, a generalist, but focus in on a particular cohort of people for a period of time rather than doing a bit of everything.
Yeah, okay, thank you. And I suppose you pulled out two enablers there as data and workforce, and both things that the NHS in particular has struggled with historically. Coming back to data, first of all, what kind of data are used or available to support population health management? Where are the main gaps?
Well, that's a great question. Thank you, Tom. So I suppose the nirvana for population health management people, I'm not really a data person, but I was on call with a good colleague of mine from Solace and PA, a chap called Paul Molyneux, who introduced himself as the chap with a pointy hat. So, we need really clever sort of data analytical people. And the nirvana for Paul and his colleagues, and I suppose a bit for myself, would be a patient-level linked data set. So for Mr. Smith in St Albans, you would have data from, at an individual level, from primary care, community care, mental health care, hospital care, local authority, social care, police, et cetera, as much data as you could possibly get on that individual, and you'd know what sort of house they lived in. In a perhaps a brave new world, maybe a bit 1984 Orwellian type world, with permission, you'd perhaps know what their daily step count was. So the best, the data at an individual level across all providers of care, but also bringing in, which I've really not talked about enough today, sort of data on their social determinants of health. As I say, what sort of area they live in, which you can get from the postcode, what sort of house they live in. There's some data called Mosaic where you might be able to get that. In some areas, they're able to focus in on older people with vulnerability because they know they've got an assisted bin collection. Somebody comes and takes their bin out to the side of the house onto the road because they're unable to do it. And that sort of data could enable you to target. So as much data as possible on each individual is the data that is required for population health management. Having said all of that, I think you could do more than enough with just primary care data.
Yeah, okay. That's interesting, because I think, often the conversations that we have are around getting that wealth of everything else in there, particularly the social or social determinants, the social care data. But understanding that actually you think there's enough in primary care data is actually a kind of a real sense check on where we are now. And actually, I suppose it's a case of what can we do with what's available rather than waiting for a perfect
exactly.
to build on.
And if I were to pick any bit of data, I'd pick primary care. I mean, we know if somebody has long-term conditions, which they have, particularly the QOF ones, because GPs are incentivized for that. We often know a lot of lifestyle data, ethnicity data, whether they're a carer or not. And we actually have quite a lot of data about whether they, in a family where there's been a child in need, or if they're a looked after child, or, it's got a huge amount of data about the individual. If we could just tap into that, just to be slightly downbeat for a moment, which hasn't been my style to date in this webinar, and normally isn't. There's some areas I go to where there's not even a data sharing arrangement between the practices and the primary care network. So that's a problem. But it's not an insurmountable problem.
Yeah, and that's another really good illustration of just the variation and the challenge, that there isn't a one size fits all, and it's going to be a long time before there is, I suppose. While we're on the subject of data, obviously that's kind of the back end of it. What data have you got? Thinking about the other end of the scale, what role do you see technology playing in population health management in terms of sort of remote monitoring, other sort of supported technologies that patients and people might be able to use? Do you see a role for technology?
Oh, definitely. And I think, again, it depends on the cohort that you're focusing in on as to how that technology could help. So just to think across the different degrees of complexity, if you're talking about primary prevention, I mean, I said about the step count, slightly jokingly, but if you were going to support somebody to, improve their physical activity, as well as having a good local walk to host them to, maybe supported if they needed it, maybe with other people because of the social benefit of it. Actually, having a step counter would be really helpful. And maybe some people would benefit from some support for calorie counting, monitoring their alcohol intake. Maybe if they're not got a mental health diagnosis, but they're feeling quite stressed, maybe some calm apps might be helpful. So in terms of, and that's, I suppose, in more of the sort of wellness or health and wellbeing arena. Another company I'm working for is a company called AIDE, AIDE, they're developing an app for people with long-term conditions to improve their self-care. Tom, I think you're aware of their work, and I think again other self-management tools will be available, but I'm just illustrating it that there are developments in tools to allow people with one or more long-term conditions to enable them to better self-management, make sure they don't forget their medication, give them information about their condition. They've got asthma, tell them when the pollen count is particularly high or there's high levels of pollution. And then when you get into, more of the older frailty, or not necessarily older, but just frail population, alarms, tools to help people keep connected. So I have myself and my brother and sister have regular WhatsApp calls, more messages with my mum, who's 86 and, uses WhatsApp and text, really well to stay connected. We don't have to speak all the time. And, there'll be lots of digital tools if somebody has a hearing impairment, a visual impairment. So, technology has completely revolutionized our lives, hasn't it? And, of course, technology is going to have a bigger and bigger role in helping people, with different sorts of needs.
Yeah, good stuff. Thanks, Steve. The other enabler that you talked about was kind of the workforce. In terms of kind of these new roles and certain roles being seen in different ways, maybe people performing different functions, what have you seen as a response from the workforce to taking different approaches?
It's really interesting, isn't it? And I was on a call the other day, part of our National Population Health Management work, and they were talking about infrastructure. And it sort of dawned on me while I was reading through the papers on my training, one of the first train rides for work I've had for a while, which was really nice. I was thinking that the most important infrastructure is the culture. So we shouldn't underestimate how important culture is for this, and it's a bit countercultural for a lot of people to prioritise on a certain area of health need, because particularly if you're a GP, you're used to trying to do everything for everybody and not prioritising. So prioritising is really difficult. The other barrier I mentioned is a lot of the workforce, when you first talk to them, want to do a bit of everything, and they want to try and provide continuity for everybody. So when you start talking about identifying some people who maybe don't need continuity so much, and let's focus our scarce continuity resources on maybe towards the right-hand side of that 3x3, people start getting a bit challenging. However, I did a really interesting exercise in a practice in Watford I was supporting, where it suddenly dawned on me that as well as segmenting the population, let's segment the workforce. And so what I did is I sent out a questionnaire to all the partners of this newly merged practice. I think there are about 16 partners, and I applied my sort of 6 care models. I probably put in a few extra ones like contraception and other things. And I said, of all these areas, just list your top 3 or 4 areas that you'd like to spend more time on. And interestingly, what came back was a complete spread of interest. Mm. So I said, look, one of the advantages of population health management is you could do a little bit more, you could do more of what you like doing. So if, like me, your interest is, urgent care, acute care, same-day demand, I mainly do triage, telephone triage, and see people with acute health needs. There'll be other people in the practice who I know don't like that so much, and they'd rather do the ongoing follow-up of people with complex needs or long-term condition management. Other people are more in the health and well-being interest area. So I think actually population health management could unlock some of the workforce by allowing them to focus in on doing more of what they like. They're still being a GP, I tell them. Even if you're mainly focused on frail elderly, you're still being an expert generalist. You're just doing more of what you like and providing great continuity to that group of people.
Yeah, that's a fascinating reflection. I suppose it's a good one for our audience when thinking about how certain conditions, certain patient populations are being managed, that it's not just about the name badge or the role that people are performing, but it's much more than that. It's how do you find the people with an interest or who are really going to engage in looking after a particular cohort, isn't it? The other thing,
I suppose we've seen people getting interested in, like, vaccination. Some GPs decide to spend a lot of time doing that. And there was just quickly wanted, before I forget, Tom, to mention, there was a practice I spoke to in Newham, and they do a lot of digital and telephone triage. And one of their members of staff moved from Newham to Scotland, but still continued to work for the practice remotely. Yeah. So that's where, technology will enable people to work, outside of their geographical area, but maybe then focusing more on the sort of, obviously on the remote side of things, because they were in Scotland and the patients were in Newham.
Yeah, absolutely. Yeah, it's certainly a new world we're living in. The last thing I wanted to touch on, and we're going to finish a few minutes early to let you get your clinical head on, but I think what are the challenges for our audience, particularly those working in industry, is how these population health approaches, which look very, or they are, a big deviation away from traditional sort of clinical ways of managing particular cohorts, kind of how people from industry, the companies that we work with, might engage in it and support it and make a difference, when actually a lot of what's talked about is maybe housing, transport, those sorts of things. Where do you see the opportunities for industry to engage with and support population health management?
That's a really good question, probably the hardest one of the afternoon, and it's been a great discussion. I've really enjoyed it. So unless I'm wrong, and Tom, you could correct me here, because maybe you're thinking about different types of industry more than I am, but I suppose where an industry is disease specific, so say focusing on diabetes or COPD, and it's something when I've talked to different pharmaceutical companies previously and done some work for them, they have talked over the years quite a lot about sort of value add services. So rather than just providing the medicine, actually providing some of the wraparound support, maybe getting into those apps that I talked about, maybe getting into more clinical health coaching that I mentioned. So, so I'm not suggesting let's say a pharmaceutical supplier of insulin would be getting into the remit of helping somebody with the other long-term conditions they suffer from when they're not in that space. However, the person's insulin management requires a lot more than insulin. It requires maybe some devices around that, but also support, whether that be from a diabetes nurse specialist or more the sort of generic long-term condition management that a health coach would provide. So I think that's my first thought. But I think population health management is a way in, and if you find an area through its population health management priorities is focusing on areas that you cover, and then that's a really important way in. And you might even be able to provide some of the tools and techniques for population health management itself. The other bit, if we're talking about industry in terms of devices and technology, then I think there's perhaps a more obvious read across in terms of some of that more holistic support that people are going to need.
Yeah, okay, thank you. So I suppose the message there is to think about groups of patients in more holistic ways, and not just how do they use this technology, be that a medicine or device. It's what do they need to enable them to live a better life, and how do they almost maximize the outcomes of using this particular technology.
Yeah, I think that's right. So some of it is about the diseases that people have. It's not that it's not important to think about the diseases they have, but in like a sort of onion skin approach, we think about the disease, the treatments, the other things that need to go along with the treatment, the support that is required, also treatment for the other conditions that the person has, and the other types of support they might need to live a healthy and productive and happy life with those conditions and challenges that they have.
Fantastic. Thank you very much, Steve. We'll
My
call
pleasure.
it to close to let you get into clinical mode. So yeah, thanks again for coming by to speak with me this afternoon. Thanks to everyone listening at home. If there's anything that's cropped up today that you want to find out more about, or want to understand what it means for you, please do get in touch with us, info@mtechaccess.co.uk. Anything to do with your market access strategies, how you're realising that, how you're engaging with the NHS around these things, please do get in touch. We're in the process of finalising our next guest for the next webinar, so please look out for the invite for that over the next couple of weeks, and we will see you next time. Thank you very much.
Wonderful. Thanks, Tom. Bye, everyone. Have a good day and a good weekend. Bye.
Thank you for watching. If you'd like to find out more about our work with the NHS or how we could support your market access goals, please email info@mtechaccess.co.uk or visit our website at mtechaccess.co.uk.